Hi you guys, it's Dr. Baker Townsend, and we're going to talk about bleeding during pregnancy. Bleeding during pregnancy is a extremely high-risk condition. It can lead to increased fetal and maternal morbidity and mortality. So you guys, you really have to be on your game. You have to be consistently assessing for external and internal bleeding and taking it serious. So we're going to go over some conditions that cause bleeding during pregnancy. The information is located in chapter 28 of your text under hemorrhagic disorders. So first thing we're going to talk about is abortion. As you know by definition, abortion is a termination of a pregnancy less than 20 weeks. If we don't know the gestational age of the fetus, we can weigh the fetus, and if it's less than 500 grams, we know that the fetus is less than 20 weeks. An elective abortion can be for social reasons, by choice, or for therapeutic reasons in consideration for illness, maternal illness. This is usually when the presence of the fetus creates a life-threatening situation for the mother. So that can be for therapeutic reasons. And then spontaneous, of course, can be from natural causes. Many times it's from a progesterone defect, usually in the luteal phase, and the progesterone just does not creep up quick enough to maintain the pregnancy until the placenta takes over. So those are abortions. That's just kind of the definition. And now we're going to talk about the different types of abortions. So the first abortion we're going to talk about is a threatened abortion. You can see here it is in A. And what's really interesting that I always say to you guys, and I want you to really remember, is that when the door is open to the uterus, the door of the uterus is the cervix. So when the door is open, you guys, there is nothing to hold the contents of the uterus in. So if your cervix is dilated, that's a huge issue and a huge problem. If it is not dilated, sometimes it can just be a threatened abortion where it doesn't actually take place, it's just threatening to. So a threatened abortion, the cervix is closed and there's some spotting. We hope this resolves, but if it does not, it can continue to one of the other abortions. An inevitable abortion is B, right here. You can see that the cervix is dilated, and remember the cervix holds in the contents of the uterus, so there's nothing, it's inevitable that the contents are going to come out of the uterus. The next one is an incomplete abortion, and here's your uterus. The fetus came out, but products of the placenta were retained. As you can see in this picture, the door is open, there's bleeding. So you guys, this is a huge risk for bleeding, of course, obviously, and infection. We worry about bacterial invasion and massive infection for the mother. Next one, D, is complete. This is an abortion where everything was evacuated from the uterus. There's no contents longer in the uterus. All of the contents came out. That would be the baby, the sac, the cord, the placenta. And then E is a missed abortion. And this is where the fetus died in utero and the cervix did not dilate. And this is problematic both medically and psychologically for the mother. Medically, we certainly don't want to do anything to provide more trauma or scarring of her cervix and her uterus. So our approach is very, very conservative. We hope that she passes the fetus on her own without medical intervention. So we don't want to do any surgeries if at all possible. Most of the time the surgery is dilation of the cervix, manual dilation, and then suction or evacuation of the uterus. And we don't want to do that because we know all of that can create scar tissue, but if we have to, if it has to happen, it does. If the mother's life, if the mom gets an infection and we're starting to worry. The other way that we can do this is by the use of cytotec or misoprostol, and that will dilate the cervix, and we hope that the contents are expelled that way. But again, we're very conservative. We do not want any surgery to the mom's cervix or uterus as we want to preserve her further childbearing potential. Septic is when obviously there's an infection. Then habitual is 3 or more successive abortions. And a lot of times, you guys, we have this one condition called cervical incompetence. They also call it cervical, there's a new term. Instead of an incompetent cervix, it is a, I'm trying to find it in your book here. The new term is cervical insufficiency. Yeah, cervical insufficiency. So I like that term better. Instead of saying you have an incompetent cervix, that you have cervical insufficiency. We like that. It's much better. But unfortunately, what happens is this cervix just opens for no reason. And sometimes we'll put a little suture around the cervix when it's in this kind of condition right here, hoping that it doesn't open. It's just kind of like an insurance policy. Around the cervix. It just kind of gives it some support. But if she starts to dilate, we definitely take off the little band. That's called a cerclage. It's on page 675 of your text. And we'll let it dilate, because if we do not, then we can have some tearing of tissues. So just want to tell you about cervical insufficiency. That's when the cervix just opens for no reason. We don't know why. And it can cause a habitual abortion. The next topic I want to talk about is ectopic pregnancy. And an ectopic pregnancy is where the fertilized ovum is implanted somewhere other than the uterine cavity. We really want it in the uterine cavity right here. We don't want it in the tube, ovarian, abdominal, cervical. We definitely don't want it in the tube anywhere along the ways. Here's tubo, ovarian, fimbrial. The only place capable of growing and developing embryo and fetus is the body of the uterus. So you guys, this will not, if you have an ectopic pregnancy, this cannot be transferred, and it will not go to term. The reason why this is such a major issue is because you can see, of course, you know about the increased blood volume during pregnancy and the vasodilation to accommodate the extra blood volume. So you can see in this tube, there's an embryo in this tube, and you can see it's only a centimeter long. Okay, it's only a centimeter long. But it just causes distension of this tube, and if this tube ruptures like it did in this picture right here, it can cause massive hemorrhage that can lead to shock. So you guys, we have to be cognizant of what are the signs and symptoms from this mother. And so her most common complaint is unilateral, sharp abdominal or pelvic pain that's one-sided, unilateral. So you guys, that's the big one. And it's very early in pregnancy. It's usually in the first trimester. You may go very small into the second trimester, just a few weeks into the second trimester, but unilateral sharp abdominal pain. And most of the time that is a tubal pregnancy. The next bleeding condition we want to look at is trophoblastic disease, or a Hydatidiform mole. What's important to understand here, there is no embryo and there is no fetus. This is where the chromosomes were incorrect to make a baby, and the placenta, there were some components of DNA that met, and so there was no baby made, but the placenta, it started to make a placenta, and the placenta overgrew like crazy, and it abnormally grew. So it's a benign degenerative process. The placenta, the chorionic villi degenerate into edematous, cystic, avascular, transparent vesicles that hang and cluster like grapes. So you can see on this sonogram right here that it looks like hanging grapes in clusters. This is how we know that you have a molar pregnancy, and you can see there's no fetus in here. This is counted as a pregnancy. So when you're doing your G and your P, this definitely is a G. There is no P because they'll never get to 20 weeks. And when you do your GTPAL, this would be considered an A. Even though there is no baby, it was contents of a pregnancy, and it did not go to 20 weeks, so it's a G and an A. So this is counted a pregnancy, but the chromosomes were incorrect. There is no embryo. So let's look at a complete mole. So a complete molar pregnancy is fertilization of an egg with no nucleus. So you can see that the sperm fertilized the egg, and then the sperm duplicated itself. So of course 46XX and all sperm contents is not going to make a person. So it does create the placenta, and that's a degenerative placenta, an abnormal placenta, and it grows very rapidly. You can see these vesicles, they can come out of the vagina. It can rupture the uterus. It can get so big. And what's interesting about this is that the size are much greater than the date. So we always talk about at 20 weeks, the uterus should be at the umbilicus. Sometimes these patients are like 10 and 12 weeks and their uterus is up at the umbilicus. And so we start to really question, why is that? Is there twins, or is it a molar pregnancy? What is going on? Or is it like a fibroid tumor, which is a benign tumor? I'm so sorry, my phone rang. So you guys, these vesicles are diagnostic when we see this on ultrasound. On ultrasound, we see these in the uterus, and we know that this is a very high-risk situation with lots of bleeding. As you can see in this picture, see how the blood, you guys, they get anemic in their vasculature because so much blood goes to this molar pregnancy. So when you do an H&H on them, it's so low because the blood volume is inside of their uterus. They're actually, it could be considered internal bleeding. A partial mole, it's fertilized. It's fertilization of a normal egg, but by 2 sperm. That's not going to work either. So the mole grows rapidly. You can see there's 2 sperm in here. So this is called triploidy. We call it triploidy. And what happens is there's just too much sperm. It's not going to be a person, but sometimes there are embryonic parts because there was some to make. I mean, you can see that if we wouldn't have had that extra guy, we would have had a person here. So some embryonic parts are made. You can see in your book on page 679 some teeth. You can see hair. I've seen a spinal cord in one. So very interesting. But of course, there will never be a baby in this kind of situation. So signs of molar pregnancy: abnormal uterine bleeding. So blood is coming from their vagina. Their uterus is really big because it grows so fast. Anemia from the intravascular blood loss. So you guys, they're not going to have the circulating blood volume that they would have. A lot of that blood's going to go to their uterus, so they're anemic. They can get lightheaded. They can have all those signs of anemia. Excessive vomiting because their HCG levels like go crazy high because that placenta is developing so fast. So they have excessive vomiting, abdominal cramps because that uterus is growing so fast. And then it triggers vascular change. And then we know that when there's problems with the placenta, that can trigger preeclampsia or hypertension late in pregnancy, which can cause us problems. So if they have preeclampsia prior to 20 weeks or have blood pressure elevations prior to 20 weeks, it could be from the molar pregnancy. Of course, there is no fetal heart tones. There is no fetal skeleton because there is not a baby. So the sequelae of a molar pregnancy, very, very frightening. We are so fortunate that we live in a time where there's ultrasound. 50 years ago, many people died of this condition. We're fortunate that people get prenatal care. We get really concerned when people are stopping to get prenatal care for various reasons, but it's very, we're very fortunate that we have ultrasound, that we can look inside the uterus and see what's going on. So it's a high risk for choriocarcinoma or metastatic carcinoma as the chorionic villi go into the uterus. It's a malignancy, happens to 15 to 20% of women with a complete, there's more evidence of persistent gestational triploplastic disease. So careful follow-up, need chemotherapy. Methotrexate is usually the drug which is most prescribed. I had a former student who had this, and she was very out about it and talked about it, and she celebrated her last day of chemotherapy. So it's very scary. I also had a friend that, 2 friends, sisters, that their mother passed from this. And so we're just very fortunate we live in a time that we can identify it and there's treatment. So pregnancy loss, you guys, really important to know to think about how someone feels. It doesn't matter what the condition is. It doesn't matter if it's an ectopic pregnancy, a molar pregnancy. All that the patient is upset about or concerned about is that they lost this pregnancy. Other causes of pregnancy loss: fetal demise, preterm delivery with neonatal death. So counseling and support is really important. You really need to be cognizant of their feelings. So they may be therapeutic or non-therapeutic. They may have maladaptive coping mechanisms, and that's okay. You just want to be really supportive and let them know that you're there for them if there's anything they need. And, you know, don't give them any false reassurances or, you know, inappropriate comments. Pepper, stop. Inappropriate comments regarding, you know, this is God's will, or, you know, you'll get pregnant again, or whatever the situation may be. I'm so sorry, my dog is barking. So counseling is very important. Now let's go on to pregnancy after 20 weeks, and this actually happens before 20 weeks, but usually we'll have some, we'll have a delivery of this, which is nice. We usually don't have a lot of bleeding with this unless there's a problem. So placenta previa is where the placenta is not in the fundus. So remember, we always say we want the placenta up here high in the fundus. And so unfortunately the placenta, for whatever reason, is attached to the lower uterine segment rather excuse me, rather than the fundus. So this marginal placenta is a placenta here that barely extends to cover the cervical os. Okay, the problem with this is when the cervix starts to dilate or to open, that will tear away from the placenta and actually cause an abruption. Here's a partial, and then this is where the placenta partially covers the os, and then here is a total previa, and you can see the placenta covers everything. So you guys, anytime there's a low-lying placenta like this, we're going to do a C-section. You can't deliver the placenta before the baby. The baby will have no oxygen. So very important to understand that this can cause massive bleeding. If she starts to dilate, you can see that she'll start to bleed, and the bleeding will be rather bright red because it's so close to the vaginal canal when it comes out. So signs and symptoms, let's look at this YouTube video real quick. So you see the placenta up here high. And we can see that if the placenta is low, it can bleed very close. This could lead to shock for the mother and lack of oxygen to the fetus. Okay. Now I'm going to go back to my slide. There we go. So how do you know it's a placenta previa? It's because it's bright red vaginal bleeding, the uterus tone is normal, and it's painless bleeding. So, hold on one second. Oops. Okay, sorry about that, you guys. You know that I'm sometimes technically not very savvy. Oops. Oops, sorry. We're just going to do this. Okay. So you guys, again, it's painless vaginal bleeding, bright red, and the uterus tone is normal. Abruption or abruptio placenta is when the placenta comes off of the uterine wall. And that is really scary. This one is a partial separation. So mom is bleeding this way, and so her, blood is coming this way and is coagulating. Baby's blood is going this way and coming out of the actual placenta and coagulating. So this would be a partial or concealed hemorrhage. This would be very, very small. But we can see it on ultrasound. That's what the significance is. And A lot of times if they have this, we keep them in the hospital. We're just super concerned about them. A partial with no clotting. So here's where it partially tore off. You guys, this baby's in massive jeopardy, and so is mom. And this was with an apparent hemorrhage. So blood is coming out. And this is torn off the wall of the uterus. And then here's a complete. The baby's getting no oxygen. The baby's hemorrhaging out his or her blood through the placenta, and it's pooling here. And mom is bleeding out her blood through the uterus, and it is pooling here. So it could be apparent hemorrhage, or you can have a concealed hemorrhage. It just depends on how rapidly it happens. So how do you know that there's an abruption or abruptio placenta? She has uterine bleeding. It could be concealed or dark, but she has a rigid board-like abdomen. It's very, very painful, very, very painful. Even if she has an epidural, the pain will break through the epidural. Very urgent, can cause loss of life to the mother and the fetus. This is a major medical emergency that nurses need to be able to assess. You need to look for fetal heart tones. Of course, if we go back here and we see that there is a loss of oxygen through the gap to the placenta, obviously here and obviously here, we'll see a decrease in fetal heart tones. So it's really important to watch your fetal heart tones, palpate your mom's abdomen. If it's rigid or firm, we know we have serious issues. So now I just want to talk to you about some assessment that you would need to do for any type of bleeding. So where is the bleeding coming from, or is it concealed? So even with abortion or abruption or previa, like, is she having vaginal bleeding, or is she not having vaginal bleeding and we're having issues with her abdomen and she's in pain? So it could be concealed. Number two, how much is coming out? Of course, we measure this in peri-pad saturation over time. We know that if she is bleeding and she's pregnant and there's a fetus inside, that is extremely worrisome. Because we don't know what is going to happen with the event of bleeding. Is it going to get worse? Is it going to resolve? And we really want to save the life of the mom and the baby. So we're very concerned about that. If she's less than 20 weeks, of course, we're going to measure because we know that the life of the baby probably cannot be saved less than 20 weeks. So we're hoping that it resolves on its own, but we need to be able to measure how much blood is coming out. So you would do that in peri-pad saturation. So we discussed that, how much is on the peri-pad. If she comes in and has a peri-pad on that she just put on and it's saturated, that would be a clinical hemorrhage. So we have serious concerns. Now, we need to look at her overall condition as far as how stable are her vital signs. So the first thing is, have her vital signs changed? And the first thing we're going to look at is blood pressure. So with blood pressure, the first thing that happens is you have a fight or flight, and that is going to vasoconstrict the vessels. And so you're going to have a little bit of an elevation in the systolic volume, because of course that is during the pumping phase, and then you're going to have a decrease in the diastolic volume because it's leaking out of the vasculature, you guys. So you're going to see a widened pulse pressure. This is going to be your first inclination that there is a hemorrhage. There's going to be a widened pulse pressure. So you can see it can go 120 over 80, then it's going to widen 125 over 75, and again that systolic elevation is due to vasoconstriction from epinorepine and cortisol. And then the falling diastolic is due to decreasing blood volume in the vasculature during the resting phase, which is diastole. Then you can see it go to 120 over 60. Is there an elevation of heart rate? Of course, the more volume that the patient loses, there's going to be an elevation of heart rate. Of course, your body's going to circulate what you have, which is compensatory, so you'll get tachycardic. The patient will get tachycardic. Then after the tachycardia, you guys, there will be a trend downward, both systolically and diastolically. So you can see we're at 120 over 60. We'll say, then it went to, now both are going to fall, 110 over 50, 100 over 40, 80 over 35. You're in an extremely desperate situation now. So you want to catch this during the widened pulse pressure phase. So this is super important. Also, you guys, you could do a pulse ox on them too, and you're going to need to throw on some oxygen as well. So here we go. So what are we going to do? Our immediate interventions: call for help, call nursing. call the help, call the desk from your room. Don't leave the room. Whatever you do, never leave the room when your patient's in an emergency. So press the call bell, ask for nursing to come in, ask for nursing to call for a provider assessment, the midwife, the physician, whoever it is on the call system. Give her O2 per 10 liters non-rebreathers. So go ahead and put her oxygen on. That's going to help her and the baby. Oh, look at that. I need to capitalize that W. While you start one or two large, you need to start one or two, sorry about that. I have a little editing trouble there. Start one or two, one immediately. You may need two if you feel like the volume coming out is somewhat heavy. Large bore IVs, an 18 or 20 gauge. We can get blood through an 18, so we'd really like to have 18s on board. 2 lines and hang fluid replacement, lactated ringer or normal saline. However much is coming out, you've got to put back in to keep her from going into hypovolemic shock. So you guys, starting these IV, the only person who does this is the nurse. The tech doesn't do this. The doctor doesn't do this. This is our major responsibility. They can help us with these other things, but you have to start the IV, so make sure that you're ready to do that. Monitor for fetal heart changes and be ready to implement interventions or prep for surgery. So if the heart rate changes, you may have to turn her to the side, you guys. You may have to, get her ready for surgery. So, just be ready and then continue to monitor the vital signs. So I think you guys can assess for bleeding, know the conditions of bleeding, and be able to perform know the bleeding conditions, know what happens and how to assess for these, and then know the nursing interventions when someone is bleeding. Thank you.